Kalimera, good morning. What I will try to do in the coming 20-25 minutes is to give you some ideas about science between children, adults, and also what we need to do together to help them better. And I think that's something also for the discussion. Let me see how I go to the next here. So I think this is already important for us to realize that this is of course not Dr. Jacobi, that's just a proud grandfather. But a long time ago, in 1889 already, Dr. Jacobi, the founder of Pediatrics in the US, said, "Pediatrics does not deal with miniature men and women with reduced doses and the same class of diseases in smaller bodies, but it has its own independent range and horizon." And I think that's very true, and it's important when we do work with children. So when we think about the critical role of drug disposition in pediatric therapeutics, there's a combination of absorption, distribution, metabolism, and elimination that will determine the drug exposure. And of course, the drug exposure will determine the drug response. And the knowledge of all these relationships between the PK and the exposure will dictate the dose. Surely during the discussion we'll come back on that, but for many drugs you're using in daily practice in pediatrics, we don't even know the good dose. So there's a lot of work to be done still to work on that. I will skip the rest of the slide for different purposes. So when we think about absorption, there's different ways of giving drugs to children. You can give it oral, you can give it sublingual, under the tongue, you can give it intramuscular, you can give it percutaneous, and you can give it rectally. Many, many ways to do so. And of course, what I don't put here is intravenous, because most of the time when children are ill, or when they're very young, we put in an IV to be sure the drug is inside the child. When we think about oral drug absorption, and again, I'm not going to talk about all these issues because that would take the whole day, but we have to realize that issues like, for instance, gastric pH, intestinal drug metabolism, and also intestinal motility and gastric emptying time are important to know if it's different in a newborn baby or an adolescent girl or boy, because it determines when you get the maximal effect of your medication, and also how frequently you have to start using the medication. Just an example to make it more practical and not to make you scared about pharmacology. It's not about difficult equations. It's about very practical things we're using in daily practice. And what you can see here, on the y-axis is the percentage of adult activity. On the x-axis, for instance, gastric acid production. And what you can see from birth to adulthood, there are changes in the gastric acid production. Is it important? Or is it not important? I think it is important because here's just an example from a long time ago, 1953 publication. So not only looking at recent publications is important to do, but we have to go back in history to get already information that we should use more and more in daily practice. And what this slide shows you is oral administration of penicillin. On the y-axis, penicillin concentration measured in the blood or the serum. On the x-axis, the time after the medication was given to the patients. And what you can see here, that preterm neonates are very well able to absorb penicillin very much still. And that's because they don't have much gastric pH that will dissolve penicillin in the stomach, that doesn't get out anymore, that is not compatible there. But when you see here full-term infants, they absorb still very nicely. But as soon as you're going to give oral penicillin to a 2 weeks old, the absorption is almost gone. So that knowledge is available. We know the changes in gastric pH. I'm a pediatrician and neonatologist, so when I was a fellow in neonatology in 1990, we gave ketoconazole in the newborn babies with suspicion of candidiasis. All these infants improved. Then we measured serum levels, they were 0. So not because of the ketoconazole they improved, it was because they made the diagnosis wrongly and they improved by themselves, but not because of us. So that knowledge is there, we should use better in clinical practice. Another thing is there's differences in how you can empty your stomach. And what you can see here is the 30-minute gastric retention, percentage of a meal that is retained after 30 minutes. And what you can see here is the postnatal age, the age after being born. And the red bars are preterm infants. And what you can appreciate from this slide is that the younger you are, the more time it takes you to empty your stomach. So when you're going to treat children with oral medication, you should also realize that the Tmax, the time that you reach the maximal concentration in the serum, is prolonged. And this is an example that really you see here, the example back in a drug called cisapride and we all know that it's not on the market anymore. It was the best drug ever I had, I think, to treat reflux in newborn babies. But of course, it was again not registered for children, but only for adults. And adults died from it because of some issues with cardiovascular QT prolongation, but that's a different discussion. I want to show you that the differences in emptying your stomach has an impact on when you reach your Tmax. This is the plasma concentrations. The children here these are the older kids, 52 to 54 weeks. These are the younger children, and you can see that the time to reach your Pmax is going to the right as if you're younger, because it takes you more time to empty the stomach. An issue that we will discuss for sure today is always how do you get medicines into children? In other words, if you're going to work with children, you need to have a formulation that will fit in. People working in this room clinically know what we do in clinical practice. We break open an ampoule and we put it rectally, orally, nasally, it doesn't matter. But for real, we don't like that as adults, so when we have to work on that, it's clear that you need to know what happens. And what this slide shows you is from a newborn to an infant, to a preschool child, a school-aged child, and an adolescent, kind of different formulations you can potentially use that are going to work in children, because you can say, okay, I develop a big tablet for a newborn baby, that will never work. So you have to know about developmental capacity of children to see whether you can give a chewable tablet, an oral liquid, where you go in the rectal route, we go parenteral, intranasal, intraocular. In other words, there's information available with some variation, of course, where you're born, because some children in the Netherlands, where I was born, have a different capacity of swallowing tablets than, for instance, here in Greece, or compared with children in Kenya, but there's a general rule here that you can follow. The most important thing, though, is always in oral drug administration that the first law of pediatric administration is that they spit it out. So we have always an issue with children that whatever you invent, they like to do this. He's very happy that he makes his father's shirt dirty, but the most important thing for us today is, that is always annoying, but the most important thing for us today is that when you develop medications that way, you have to realize that it should be palatable. It should have a reasonable taste, or otherwise it's even getting much worse. So I think that's a very important rule to think about. You can use the skin, so different transdermal drug absorption, all kind of issues here again for barrier thickness, blood flow, temperature, local pH, again, too much to talk about in 20 minutes, but I want to show you, though, that we know something about rapid changes, for instance, in newborn babies. What you can see here is a child born after 26 weeks. Normally it's 40 weeks, as you all know. So the baby is born 3 to 4 months early. And on the first day after birth, you can see the stratum corneum hardly exists. So when you develop a medication that wants to be used through the skin, it will go very fast inside and may be very toxic. And then the same child, 2 weeks later, has the same stratum corneum as the child born full term on the first day of life. In other words, as soon as you're born, the maturation dramatically changes. So when you're born as a 24-weeker, a week later almost, or a little bit more than a week later, your skin is the same as being born 4 months later. So that's something we know, but when you develop medications, you have to apply that to that development. And we have a lot of nasty effects of enhanced skin permeability and the absorption, especially in newborn babies. There's drugs like sulfadiazine, cardiorespiratory arrest because of the enhanced absorption, topical steroids, getting adrenal insufficiency, Cushing syndrome, laundry detergent can give all kinds of issues, hepatomegaly and acidosis, and things like talcum powder can get death in young children because of that absorption. So I think it's not only theoretical, it's very important to think about adverse events. Volume of distribution is, but is it always something we talk about in pharmacology? Most of you in the room will be very scared about volume of distribution. It's just mathematics. You add something in a cup like that, and then you can measure then the total amount of given to somebody you measured in that cup. That's the amount that is divided by things, and you put it in a larger cup, the volume is different. So that's what volume of distribution is. So when you read about a drug and it says 1,000 liters per kilogram, don't get worried, it's just a mathematical issue. We know something about it, though. This is a slide showing you age-dependent changes in body composition. Extracellular water in orange, intercellular water in green, protein in gray, and fat in blue. And what you can see that the premature baby it persists only at water, more or less. It's a bag of water. It's very strange to realize it, but it's true. But what you also can appreciate is that, for instance, the extracellular water compartment changes from the premature to the newborn to the 4-month-old, etc. And when you have a drug that needs to go to the extracellular water and you need a certain peak level, like gentamicin, you need giving much more to the premature baby, otherwise you never reach a peak level. It took us a long time to change that in clinical practice. So the knowledge we have sometimes with each other, it's difficult sometimes to convince physicians and nurse practitioners because we're very stubborn, and I'm one of them. So it's not because you're stubborn, I'm stubborn myself too. So what is the impact? For instance, just here looking at the peak gentamicin levels, the same dose given in milligrams per kilogram, the more young you are, the lower the peak will be. And it has to do with this volume of distribution. This large orange part I showed you about the extracellular water. So the older you get, the better the peak, and you need a good peak to kill the bacteria. So what we have been doing in pediatrics, especially in young children, we also have been afraid to harm. But probably sometimes we were harming with not using the right dose in these infants. Think about metabolism, many steps. Most drugs are metabolized by phase 1, cytochromes, all kind of enzymes. And again, I'm not going to talk about it, and we're not going to ask you questions afterwards about all the information I gave you in a short phase. Phase 2 step, because most metabolites need to be excreted, and this is just showing that urine production is very important. And I showed this little boy just because of making it, hopefully, that you stay awake listening to my presentation. But whatever you do with drugs, when you have to work in young children in the first 2 years of life, for sure, renal function is key. So when it is midazolam or morphine for the liver, you make glucuronides, and they have to be excreted. So renal function is very important to think about. What do we know about all these enzymes? And again, forget all these numbers. We know nowadays, and it's since 2008 actually, that we have different classes of enzymes, class 1, 2, and 3, that are in the liver. But also, hopefully you go home today by thinking that metabolism is liver. It's not true. Metabolism is liver plus intestine. 50% of a lot of activity happens in the bowel and not only in the liver. So new knowledge is getting there. Why is this there? Because we know now that there's different developmental changes. The class 1 enzymes, for instance, this is measured activity in fetuses between 10 and 26 weeks gestation. This between 26 and 40 weeks gestation, the normal gestational duration. This in children in postnatal ages between 0 and 6 months, and here between 6 months and 18 years. And what you can appreciate is that for these class of enzymes, there's more activity in utero than after birth. Class 2, there's some variation, but no real relationship. So both in utero and after birth, there's more or less the same happening. Class 3 is the largest class, as I showed you before. Hardly any activity before you're born, and then it appears. Of course, these enzyme systems were never developed by our developers, so to say, for medicines. But we're talking about today about medicine, so I think it's important to have that knowledge shared with each other. To make it more complex, and that's going to be very important in the coming years, we know that it's not only the development that's important in children, because we know that it's a developing, growing individual. Also, it's important that some of us have different capacity to handle medications because your father or mother didn't give you certain enzymes. So pharmacogenetics, pharmacogenomics is coming closer. In adults, already very much incorporated. In kids, coming. So what you can see here, for instance, is developmental changes of one of the enzymes. And again, forget the number. What you can see, before you're born, there's more or less the same. And after you're born, when you look in months, there is a clear increase in the first months of life. Development plays a big role. Because when you go to years, there's not much change anymore. So when you don't do the studies in the first months of life, you would miss that developmental change. And what will happen, the young children will get overdosed, and 2 or 3 months later, the same children will get underdosed when you don't think about these changes in development. To make it more complex, that's the only slide really complex, is the fact that in addition to development, some of you in the room will have a slow metabolizing capacity. Some of you need coffee in the evening to stay awake. Some of you need coffee in the afternoon and you don't sleep anymore. That counts also for these issues. So this slide shows you the development at postmenstrual age of gestational age. And what you can see here, I made red circles here, these are people who are slow metabolizers because their parents didn't give them anything to metabolize certain drugs. And what you can see here, when you wouldn't know that, seems like a normal development. except when you have a certain genetic background, you don't develop. So these things are going to happen. We have to work with each other in pediatrics to find out where development is the most important player and where genetics are going to play a role. And that's going to happen in the coming 5 to 10 years for sure. A drug that everybody knows, paracetamol, in the US we call it acetaminophen. I just show you that because there are different pathways, and also the pathways are different. We're only afraid for this pathway because it produces the liver toxicity. But I want you to show this only that between a newborn, a 3 to 9-year-old, a 12-year-old, and an adult, there is a differences in how much goes to this pathway, how much goes to that pathway. And again, don't remember this, but realize that we need to know these kind of things to predict side effects and to predict adverse events in these newborn babies. And when you look at half-life, and half-life is the time it takes to go from 100% in the serum to 50% in the serum, you can see that a preterm infant has a half-life of 290 minutes, and it gets a little bit more term, 265, 210, and when you get older, it's 126. In other words, the more premature you are, you have to be careful with this medication that you don't accumulate and really poison your liver. Renal function, the only thing I always try to mention, so I'm sure that you also use the Red Book for infectious diseases. Excellent book for looking at varicella, what to do when the baby is exposed to that. Never use it for dosing in newborn babies, because it's wrong, because and it's from the American Academy of Pediatrics. 60,000 pediatricians are participating in there, but the dosing you can't use, because newborns are seen as the same individuals in the first 28 days of life. And this slide shows you, and I only want you to look at the term infants, the renal function in the first 2 days of life is 30, a week later it's 50, a week later it's 70. So in 2 weeks, the capacity of the kidney in term infants dramatically changes. So the newborn in the first days of life is completely different how to handle medications than 2 weeks later. Makes it complex, but therefore we have to work together. Fluconazole, a drug probably used by many of you. The only thing I want to show you here is that, for instance, the half-life again, from the first day of life it's 88, 6 weeks later it's 67, a week later it's 55. Dramatic changes in clearing capacity that will influence how you handle medications in these infants. Don't worry, I'm not going to talk about anything about this slide, but it's not only development. We know all the different steps. There's transport in the brain. We know that there's all kind of mutations here that you're all different in this room. Not only how you look and how you dress, but also how you handle medications. Intestinal transporters, transporters in the bowel, a lot of things happening here, and I think it's important to realize that we're just starting to learn the first pieces. So what are the facts? Children are not small adults. Sounds like an open door, but they have different pharmacokinetics. So in other words, there's different way how children handle medications who got on board. I don't talk today about the pharmacodynamics. In other words, when there is pain, you will give morphine or something else to relieve the pain. But children will react differently on different ages in the pain relief also. 70% of drugs are not labeled for pediatric use in children. So the majority of children you're treating, we don't know really what we're doing, and that's something we should, and it's not in Greece only, that's everywhere in the world. So it's not, I'm talking here to say, here it's 70% and in the Netherlands it's 10%, no, it's everywhere the same. So we have a lot of work to do together. And what happens many times is that drugs are developed, and what happens is that, oh, there's also still children. Children can go to people of the Congress and say, listen, we're here. We have to do that for them. That's very important to realize. And of course, we need to find ways that we give drugs that are effective, but also very safe in children. Tip of the iceberg, on purpose I show you this because we're just starting to get more information there. A few slides before I stop today, and there's the in silico child. It sounds very strange, but we know nowadays, in the past people were worried about studies in children because we needed to have 10 samples in every child to know something. Now we know that you have to do 1 or 2 samples, and you have much more information with all kind of modeling that's available. We know a lot of information, and I showed you some of them because of the time duration. There's much more knowledge there. Also important to do this kind of thing. It's a very interesting, I think, example of how you should not do things. So there's a protocol, nonsensical elements in the protocol. Consent language, and I'm sure that Dr. Rosa will talk about also later about ethical issues. So if the patient is a female, All childbearing potential, she must not be a pregnant or nursing mother. If she's sexually active, she will be required to take precautions to avoid the possibility of becoming pregnant for up to 30 days post-study ingestion. The use of oral contraceptives, introducing devices, barrier methods, blah, 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 are accepted methods of birth control. A pregnancy test will be done at the start of the study. Sounds all standard wording. And this study was interesting. This was a study, a neonatal pharmacokinetic study. So in other words, I do it on purpose to let you laugh a little bit, but it's really happening. Sometimes what happens, the protocol come in, and the only thing that has changed is the word adult into child. And I hope to make clear to you that is not the way to go. Also important when you want to do studies and looking at pharmacokinetics, you need to know something about how much blood is going on. So when you do studies in premature babies of 500 grams, the total volume is 40 mils. So what you can take is probably 1.5 that will be allowed ethically. So when you go through a full-term child, you can already go to 12, and in children older there's more. So when you do studies in children, and we are obliged to do them now much more, you need to be sure that you have already analytical technique available that you can use microliters instead of mils. Otherwise you're never going to be able to do the studies. And also you have to find ways that you don't take these 10 samples, as I mentioned before. So a lot of things, you need to select the population, the dosing scheme, how to get the drug in. All these things are important to work on. And of course, clearly, there's nobody in this room who can do that alone. And taking care of these babies at my profession, this is 380 grams. Still, this is a good one, otherwise I wouldn't show the picture. But still, these babies have a lot of things to be done. And there's a lot of things going on, and when we're not taking well of the medications, we're adding more risks to their lives. And there's the one last slide. I think it's important when you develop medications for children, they do not think that the worse the medication tastes, the better it works. Sometimes we try to convince our children that if it's bitter, it's better for your health. They don't take that. So when you look in a survey that was done, when do things go wrong, is that when you have a drug that has to be dosed 4 times or 5 times a day, it never works well. When it doesn't taste well, and of course when there are side effects. And we have to be realizing that when you want to have children taking the medications for the whole week, you need to be sure that you have a good formulation, and it should also be tasteful and perhaps looks also very cool. The last slide. Nobody can do this alone. We need to work together. The government has to support what we're doing. Industry has to be involved. Academia has to be involved. And don't forget to involve patients and parents of patients, because a lot of diseases in children happening very rarely. That's good, because it's happy that children not having the diseases that many times, but therefore we have to combine efforts and not only do a study in Greece, we have to do the studies in Europe and even more international when it's a rare disease. Thank you very much for your time.